We have an endotracheal tube, some Goodell airways, and a variety of laryngoscope blades. An endotracheal tube has a number of components. It has a 15mm connector, which connects to a breathing circuit and is made of PVC plastic. It has a cuff which can be inflated. The bevel is cut at an angle and it has a separate port on the side called the Murphy's eye. This prevents the endotracheal tube from abutting into the tracheal wall. This black line denotes where the vocal cord should be once the tube has been inserted. 8 denotes the internal diameter of the endotracheal tube, and along the top of the tube we have markings which denote the length of the tube. The laryngoscope blade comes in 2 sizes. This is a Macintosh blade. It consists of a handle which contains batteries to power the fibre optic light. It is a left-handed instrument, and the L shape will allow you to visualize the glottis. This is a size 4. This is known as a McCoy laryngoscope, and it has the same curvature as the Macintosh, but has a hinged tip which is controlled by this lever. This assists with difficult intubation, where the vocal cords may be difficult to fully visualize. The patient is given oxygen to breathe. The bed is lowered. Intravenous analgesia is administered in the form of fentanyl. Propofol is then slowly administered. You can test the depth of anesthesia by checking for a vocal response and also by touching the eyelid to look for an eyelash reflex. Ensure the head is in the head tilt chin lift position. Insert an oropharyngeal or Goodell airway to check if the patient can be adequately ventilated. We are looking for chest rise, misting of the mask, and a CO2 trace on the monitor. Once this is confirmed, you can proceed to paralysing the patient and insert an endotracheal tube. For intubation, we will have the patient in the supine position with a pillow under his head. The neck is flexed and the head is extended. The muscle relaxant we have used takes about 90 seconds to work at the doses we have used, so we will gently ventilate the patient. Here we are using a video laryngoscope, which is a left-handed instrument. Insert it into the mouth, making sure not to dislodge any of the teeth or cut the mouth. We can see the epiglottis. The blade sits in the vallecula. This would be a grade 2 or 3 intubation, where you can only see the posterior aspect of the cords. With this intubation, we'll use a bougie to aid the tube entering the vocal cords. The tube then passes over the bougie and into the trachea. The bougie is removed. Inflate the cuff to make sure there is no leak. Look for chest rise, a CO2 trace, and auscultate the lungs to ensure that we have equal air entry bilaterally. This ensures we do not have bronchial intubation. The tube is then secured with a tie. The balloon is important to prevent aspiration of gastric contents.